All right, welcome everyone to our webinar today. My name is Amanda Demmer. I'm the Program Coordinator for Community-Based Research Canada and the moderator for today's session. Today we have our first session in a brand new series that we're calling Moving the Dial. Our first series presenter is Dr. Ameil J, who'll be sharing a project that moved the dial on health equity advocacy through community mobilization and solidarity. Before we jump into that, to speak briefly about this theme of moving the dial and what it means for CBRCanada, CBRCanada Board Chair Steve Dooley will share some words.
Well, thanks very much, Amanda. And I want to welcome everyone, and I want to give a special thanks to Amanda and Sarah for helping us get organized today and putting on this webinar. I just want to introduce myself, Steve Dooley. I'm co-chair of CBRCanada, and my daytime job, I'm executive director of Simon Fraser University Surrey campus in Surrey, British Columbia. I live in White Rock, British Columbia, on the unceded territory of the Semiahmoo First Nation, and work very closely with Semiahmoo in my work in the community. So we came up with the title "Moving the Dial" because at its core, community engaged research is about action and change. And we're in a time of the world where we're dealing with all these wicked challenges and problems. Health equity is a huge one of them. Indigenization of the Indigenous culture, reconciliation, equity, diversity, inclusion. There's all kinds of challenges. And we wanted to come up with the term "moving the dial" because we want it to be about action and change. And we want to really think about, how are we measuring that change? How do we know when we've moved the dial? And how can we document that and in a manner that makes life better for the people that we're working with in our community? So we really want to focus on that concept of change and action. And I can't think of a better way of starting this series with the webinar that we're going to have today. And I'm really looking forward to participating. Again, I want to thank everybody for joining us. We know how busy everyone is. And again, great to be here. And Amanda, I'll turn it back over to you.
Thank you, Steve. Thank you for being with us today to join us. This is certainly an exciting series and a great way to start it off. Steve also mentioned Sarah, who you'll see with her camera on right now. Sarah is a volunteer with us, and she'll be monitoring and pasting some links in the chat for you throughout. If you do have any issues with tech or anything like that, you can let Sarah know as well. Before we jump into the presentation, just to acknowledge this presentation is brought to you by CBRCanada. The CBRCanada Secretariat is located out of Wilfrid Laurier University, which is situated on the traditional territory of the Neutral, Anishinaabe, and Haudenosaunee peoples. CBRCanada is a membership-based organization whose mission is to advance community-based research and excellence in Canada by strengthening partnerships, building capacity, mobilizing knowledge, and championing community-based research among individuals, communities, and institutions. We are a social enterprise. We're funded by over 50 institutional members. And as part of our programming that we provide to our members, we host events like our webinar and our live discussion today, as well as our community of practices. And we have various information on events, resources, and everything like that on our website. You'll find a link to our website in the chat. Sarah will share that with you now. In the spirit of reconciliation and truth, CBRCanada opens each e-learning event by reflecting on and amplifying the goals of the Truth and Reconciliation Commission's call to action. Each month, we pick a different call to highlight that is relevant to the topic. So this month, since we're talking about health equity, we're highlighting call to action number 19, which begins by stating, we call upon the federal government in consultation with Aboriginal peoples to establish measurable goals to identify and close the gaps in health outcomes between Aboriginal and non-Aboriginal communities. CBRCanada is committed to continual reflection on the interconnections between truth and reconciliation within the various topics we approach using community-based research. We're also committed to continually engaging with and learning from diverse Indigenous peoples across Canada. Our agenda today, we finished most of agenda item number 1 there, our opening. So we'll be moving on shortly to our webinar presentation. This presentation, as you may notice, is being recorded. The question and answer period, which will follow the presentation by Dr. Ameil, will be recorded as well, but the live discussion will not. These live discussions are the most exciting part of these events often. That's the chance for us to learn from each other, to engage in discussion with each other about the topic and about the presentation that we've been given. So we highly encourage everyone who's able to spend the full 2 hours with us to stick around for that live discussion. We will, of course, have a very brief closing at the end of the event before we send you all on the rest of your way for your day today. So Sarah's going to share a link now in the chat that'll have this agenda in case you'd like to follow along with us. There's other information on the agenda as well that we'll get to when we introduce the live discussion. Some final housekeeping before we begin. During the webinar portion, please stay muted. You can keep your cameras off as well. If you have questions for the presenters, you can paste them in the chat and we'll address them at the end of the presentation. So please, if you have questions that come up throughout, paste them in the chat as they come to your mind. We'll scroll back through, make sure we don't miss any, and get all of those questions to Ameil during the question and answer period. I think that's about it. So I'm very, very pleased and honored to be introducing today's speaker, Dr. Ameil Joseph. Dr. Joseph holds a Master's of Social Work. He's a registered social worker, and he holds a Ph.D. He's an associate professor at the School of Social Work at McMaster University and academic director of community engaged research and relationships. Ameil has over 10 years of experience in social work and mental health fields in governance, hospital, supportive housing, settlement, crisis respite, forensic assertive community treatment, and community-based early interventions. So I'm going to now stop my screen sharing, mute myself, turn my camera off, and pass it over to you, Ameil.
Thank you. Good afternoon, everyone. Thanks for having me today. And I know there's a lot going on in the world right now, but hopefully by the end of this talk, you'll see a little bit about, understand a little bit about what I do and share some of my feelings of hope in community-based work and community-based research. I think, people have been watching and appreciating, sometimes in horror, the exacerbation of bigotry and hatred that many have tied to this particular historical moment. We've seen images of hate groups organizing and hate incidents continuing at frightening rates. And much of this is often talked about as racism at the individual level. And at the same time, these incidents have helped many appreciate the scope and impact of things like anti-Black, anti-Indigenous, anti-Muslim, anti-Asian, and anti-Semitic forms of racism, and the ways they operate in different sectors. You'll notice that I often refrain from using terms like Islamophobia, xenophobia, xenophobia, as they sometimes direct our attention back to the intents of individuals rather than on the ideas and how they are shaped and supported by policy, history, systems, and structures. And those words imply a kind of psychological pathology as an anomaly rather than have us engage in solidarity around issues of complicity. Canada has its own unique histories of race, racism, racialization, and colonialism that I would say we often don't acknowledge in the dominant ways we talk about history. When I was younger, we rarely talked about residential schools in Canada or how South African politicians came to Canada in the 1940s to learn from racism here in the Indian Act, to learn about how to use status cards and the reserve system in apartheid in South Africa. It would take me several weeks to talk about things like Chinese head taxes and Japanese internments that turned away ships of South Asian and Jewish people, of chattel slavery, and Black settlements erased, and how those histories frame civil and social relations and policy and practice and law in Canada. In my own research, I've traced some of the historical pathways that discriminatory ideas in the ways that they've shaped mental health, criminal justice, and immigration policy and practice in Canada specifically. And these racist ideas took hold many years ago. I think our job is to think with others about how those ideas sometimes have been divorced from their original projects, yet continue to operate with similar outcomes today, how they operate within professions and disciplines and practices in policy and law and impact communities. They affect how we think about capacities and capabilities and excellence in terms of threat, burden, and risk in racialized ways. And so, when I say these things, it's not about you having to identify as a bigot or feel guilty. I think that reaction all too often comes from a place of privilege and often undermines our work to listen with community to those who experience racism and act in accountable ways to respond to our complicities. And these matters are really local as well. I'm in Hamilton, and Hamilton has ranked in the top 3 in terms of police reported hate crimes for several years. And we have had some significant hate-based atrocities occur in Hamilton, including arson, attacks on Hindu and Muslim places of worship, racist symbols found on synagogues, and ongoing issues with racial profiling and policing. And all of these matters here in Hamilton have historical roots. The KKK were established in this area, well established in this area. The histories of Black settlements and slave trading in Hamilton are often omitted in the tellings of histories of Hamilton as well. I often tell the story of Hat Street in Dundas. This book in the center tells the story of Sophia Pooley, who was purchased along with their sisters by a man named Samuel Hatt, actually from an Indigenous leader, Joseph Brant, both of whose names line our streets, our towns, our institutions, often today without recognizing the racism behind these stories built around us. Well, I think, when I talk about matters of systemic racism and health equity and matters of justice, I need to tell you a little bit about me. I'm a descendant of indentured laborers brought to work in Guyana via colonial rule. On the left there is my grandfather's birth certificate. On it is a reference to my great-grandmother. It's just a misspelled first name. Her origin is identified as a boat, Foyle 1889. The vessel she was carried on is a 3-month-old infant, a vessel owned by a colonial contractor carrying indentured laborers to Guyana to soil and sugarcane fields. The only other information is a registration number. It says Cal 40711, registration number. On the right is my great-grandmother's immigration pass, a document that outlines her caste in a pejorative. The word is chamar, a word to describe Dalits or untouchables. She was someone made into a number and an insult, divorced from land and place. I think about this often, how the trajectories of erasure and dehumanization shape us in community, and how understandings of identity can be understood beyond add and subtract calculations of oppression and privilege that oversimplify all too often how we live the impacts of history. I have come from a cast of people who intergenerationally have been treated as outcasts. It shapes how I think about numbers, how I think about documents and research and data, and definitely how I come to this work. And everyone has their story. And much of this complexity is all too often unacknowledged. I raise these contexts because I feel like they're not named enough in how we talk about contemporary inequities. These contexts permeate our systems, services, programs, and disciplines. And, over the last couple of years, more so, I would say, we have seen quite a few reports that share things about racial disproportionalities as just that, often without an embedded analysis that even surfaces the problem of the racial histories of blame and the portrayals of types of people as threat or burden, infused with racist ideas of hereditary, cultural, or aptitudinal lack. And we saw quite a few examples of this in the ways that racial disparities were depicted in relation to COVID-19 and infection rates. And I would argue as well that I think there's a growing appreciation in Canada that racism in healthcare is a kind of pervasive issue. It's a topic that has found its way into public media and government. And this is a time when we should be taking more action to address it. So here's the story I'm going to tell. And in Hamilton in October of 2020, we're seeing that some 50% of COVID-19 infections were among the racialized population here. And there were calls for more race-based and socioeconomic, socio-demographic data collection to get a better sense of some of these disparities. And I was working with a number of folks who wanted to do something about it. In May of 2020, a group of doctors and professors and community leaders with experience and interest in equity work wrote to Hamilton Public Health, and we recommended that any collection and analysis of race-based data included the processes and methods of collection, that the processes and methods of collection be developed collaboratively with community members and local leaders and experts who live and do anti-racism work, research, and analysis often. We also recommended the establishment of a community advisory committee to structure this into the work to support a responsive, engaged, inclusive, and accountable approach that would improve the quality of analysis and its impact on care in Hamilton. So it just didn't end up in a report. And the reasons for this were shared with Hamilton Public Health, including the histories of collecting data on inequities without it resulting in change to resource distribution or programming or services and those kinds of things, these old problems that we all know. And these weren't new conversations. Many have written about these problematics that rely on the collection of data on race to convey action where old relations and inequities and injustices are not only maintained, but in fact solidified. Professor Ronaldo Walcott has written recently that there are indeed some truths about calls for race-based data. There are also many half-truths. Evidence is important and few would dismiss evidence as unnecessary. However, race-based data can quite frankly slow down reform. And in that context, doing the research when a problem is already identified and solutions known means that the collection of race-based data does not only, well, it doesn't add much to policymaking. In fact, in some cases, it can do more harm than good. When you package people into general types and only talk about them in terms of threat, risk, burden, lack, disparity. So race-based data collection, as currently articulated, is a response to a set of political concerns masquerading as if it is the answer. Alana James wrote, that personal information, including health data, has to be protected, whether it's identifiable or de-identified or anonymized, and that laws and regulations, policies, and substantive enforceable penalties are the kind of minimum preconditions that must be in place before more race-based data is appropriated and collected and circulated on people, about people, without them having a say in what happens with it. That group that wrote the letter that I was talking about earlier broadened. We had meetings with Hamilton Public Health. We even developed terms of reference for that group. We did so on our own time, on evenings and weekends, for nothing. And we even applied for a seed grant, which we won from the McMaster Institute for Health Equity to help launch our research work. We made it clear that we believe in the need for people to be involved in how they are identified, how they are described and analyzed, to allow for transparent data collection and analysis, and that we believe that community feedback and insight and analysis needs to be empowered with the authorities to effect change. We raised issues around the categories being used, the issues of donor ownership and access and control and possession. We submitted this to them in July of that year, and we didn't really receive a response. Then we heard about a report being released about demographic data in October. So we decided that these issues, were too important to avert our gaze, and that a community conversation with people who've deeply thought about these issues was necessary. And we shared our analyses and our perspectives and our rationale, the importance of doing this work, and the recommendations for our group was largely ignored. So we took the show on the road. In December of 2020, we held an event to explore some of these very issues, where we might resist mechanisms and relations that would wield data about race without analyses that highlight what we need to do about racism. So in December of 2020, the Hamilton Vaccine Readiness Network began, and they began convening, and it was a committee of health and community leaders who worked with public health to think about priorities for vaccination. And I was invited by those who knew me through this work, with my work with the Hamilton Center for Civic Inclusion and the Disability Justice Network of Ontario. So I joined, and many community leaders took the opportunity on the Vaccine Readiness Network to ask how Hamilton Public Health was addressing disproportionate rates of infection among the racialized population in Hamilton. And we suggested a more nuanced approach to data collection that considered the impacts and experiences of marginalized populations, the need to dedicate outreach and prioritize these highly impacted groups. We raised it, discussed it, repeated it, and action really wasn't happening. Action wasn't taken. So we took our own action. We wrote a letter to the network and to Hamilton Public Health, outlining their urgent need to address these disparities with real material actions. And when we didn't see an adequate response, we took that letter and went public with it. And over 500 Hamiltonians signed on in support. And in the letter, we highlighted that we had been calling for action since December of 2020. It was then April 2021, and nothing had moved. And this started to get some media attention, and there was a growing group of Black and other racialized community members and leaders and organizations that serve marginalized populations that rallied in solidarity to take on the work of helping to establish clinics and services to prioritize those being hit hardest by COVID-19. So you had Black and racialized health leaders and community organizations and community members, myself included. We began meeting to develop plans to address those needs. And Hamilton Public Health agreed eventually to include us in the prioritization work. And then it was just a mass of these community organizations and leaders that came together to do the work. Hamilton Urban Core Community Health Center, Refuge Newcomer Health, Compass Community Health, Assertive de Santé Communautaire, the Hamilton Center for Civic Inclusion, the Disability Justice Network of Ontario. They all worked together and agreed to take on the outreach, the bookings, the clinic operations for what became the Restoration House Clinic. We divided up the work and got to it. And most of these organizations at the beginning did this off the sides of their desk for nothing. And later, via more pushback, more advocacy, more organizing, some funding was made available to cover the staffing and labor required for the clinic. Droit de Desne Aboriginal Health Center, the Hamilton Regional Indian Center in Nawassa set up a clinic at the Perkins Center for Indigenous people as well through this work. And as soon as it hit the news, we began receiving a lot of hate mail and racist messages. So as soon as the racist social media trolls heard that there was a clinic prioritizing Black and racialized populations for vaccination, there were just torrents and torrents of hateful messages. And the initiative was targeted on extremist and white supremacist websites. It was a scary time. It was a difficult time. It was a difficult part of the work, and made me think about what my responsibility is in those moments, working with community members and leaders to also create spaces for care when doing this difficult work. A group of Black and racialized health leaders and community leaders also took the calls for structural change further to recommend changes to the structure of the Hamilton Board of Health so that its members also were comprised of more than city councilors, which it is now. So there were built-in perspectives from community and health leaders, including and especially those who work with the most marginalized in Hamilton. And there have been, this is ongoing work, but there have been letters and meetings and delegations and at city council, which is also the kind of work that happens when you're engaged in these growing relationships that are beginning with action. And this advocacy effort is still in progress. And in the early days of the clinic, there were ways to book through the City of Hamilton booking system and phone line, and the community agencies themselves were doing bookings and outreach manually. And the collective suggested that, community-based booking and outreach needed more support. Eventually, the work of this prioritization initiative was transferred out of public health to primary care, the provincial system. And then we saw a bit of a shift. We received more support for community-based outreach and bookings. Refuge Community Health helped lead the work going forward. So it really became a community-driven, community-led, community-owned, community-operated, community-responsible project. And the initiative, now led and run by community health centers and community leaders and organizations, developed agile plans for mobile clinics at numerous locations, disseminated information through in-person outreach. They did it online, they did it in social media, in multiple languages. We held specialized clinics for people with disabilities, made clear that health cards weren't necessary. And thousands and thousands of people in Hamilton had been receiving their vaccinations through that initiative. I personally received emails and messages from individuals and families that shared, their gratitude for the clinic, and stories about having had such great experience that they had all of their family members and extended family go to the clinic. It was good. It helped counter kind of like the weight of the hate as well. But the work continued. It continued through walk-ins that were established in the Hamilton Public Library, the Barton branch, and the solidarities and relationships built here. They began through collectivity and resistance. They merged through advocacy. They stayed focused on need. And this is the kind of story you might not see that often or spoken about as media pick up on bits and pieces now and again. I thought I would tell it here because, after all of this, we thought there might be a number of ways to share this story. And we wrote it up as a journal manuscript. It's in review right now. So like in the end, when you kind of retrospectively take it all in, it has you think about this community-based research project and what it means in terms of relationship and ownership and accountability and responsibility and action, and where those things happen in a particular timeline that sometimes we impose as community-based researchers on others. And the kinds of struggles you engage in are really complex. Sometimes we can try to tease them out in oversimplified ways that don't speak to the needs that are before us. And when we approach community-based research with that level of simplicity, it can get in the way of action and change. And it definitely can get in the way of relationship building. So I began speaking about the ways that these times can definitely be described in terms of all we have lost and the harms that continue and the devastating context of systemic, historical, and contemporary inequities. I could probably give another talk on the systemic racist practices of undervalued labor of Black and other racialized health and community leaders and members, the erasure of their contributions, and the systemic ignoring of their ideas. I'll leave that for another time, or maybe it'll come up in discussion to get into more detail. What I hope for today is for folks to also see just that hope. It would be easy to think about this work in oversimplified terms, and that this work was about collecting race-based data or doing community engaged research or separating services or representation. I believe that kind of analysis sometimes undermines the work. I'll stop there. Thank you.
Thank you, Ameil. I think I can speak for everyone when I say that was such a enlightening and important topic to be discussing. And I'm grateful that you shared as well kind of your own personal story, but your present story. It sounds like this whole research project has been one that's been very personal for you. And you've mentioned things like receiving the backlash from this. So it's a place of vulnerability that you've been sharing this with us. And we're so grateful for you to that. As well as for the work you've done really to move the dial on health equity through community solidarity and action and advocacy here. So we'll open the floor for folks who have questions for Ameil. So feel free, please just post in the chat. I see so far it's just lots of folks saying thank you for the lessons learned and shared. But please, folks, share your questions for Ameil, and while you're thinking about those, and Steve and Sarah, if you have questions as well, feel free to ask. I know one question that came to my mind, Ameil, since you are a researcher as well. There's a lot of lessons, it sounds like, that were learned for you through this process and this advocacy and this project that you took on. How will what you've learned in this, and you started to touch on this, I think, but how will what you've learned through this process change the way you approach community-based research moving forward?
You know, some of these relationships that I have in the community are old. And, you know, the Hamilton Anti-Racism Resource Center is now an independent not-for-profit, and Lyndon George is the executive director. And, you know, years ago, I was part of the work to repeatedly fight for that thing to exist. And I've also done a lot of work with the Hamilton Center for Civic Inclusion. They're working on an online community-based hate reporting platform to connect people to supports who've experienced hate. And I'm on the board now of the Disability Justice Network of Ontario, which is now also a not-for-profit. They established themselves. I've built relationships with people, and I speak of them like relationships through organizations. But those things are meaningful and important. They shape what I do, the text messages I receive from people, the emails I get about wanting to debrief about a meeting they had or an experience they had. And all of those are forms of knowledge that shape how I listen and understand and where I begin. And so it's really had me rethink how I start. where I begin and what I begin with. And what I often find that now I'm listening for the way that I can use like my skills, my position, my expertise to contribute in ways that amplify work that has been in progress, that is often unnamed, unseen, sometimes dismissed, omitted, rejected, suppressed, to nudge it forward with others. I think that has shaped how I think about community engaged research overall, maybe forever. And I'm trying to figure out how to write this all.
Well, and the themes you're coming up with there, talking about really the value of relationship building in the research. And if there are any folks on the webinar today who joined our last webinar in December, that was the whole focus of our webinar, was building relationships and authentic relationships, and how do you do that well when you're doing it in community-based research. So
Do you mind if I ask, Amanda, if I ask a question? Ameil, first of all, my goodness, thank you so much for that. That was just beautiful, the way you talked about your own personal journey and the connection to the relationships. And I really liked when you talked about feelings of hope and in your work going forward. I'm just curious about, you mentioned a little bit about your position within McMaster, like, you know, as a professor, and I'm wondering, and you talked specifically about the relationships, and I guess I'm coming at this from somebody who is kind of a university administrator guy. Is the position, how does the position within the institutional structure of McMaster either helpful or not helpful in supporting the work that you're doing in the community?
Right. I think if I'm new and people don't know who I am, and I kind of like just show up and start asking people to participate in some sort of project, that will and has been taken up as kind of an intrusion, an unwelcome one. And it goes along with a history of universities doing this kind of thing, you know, dropping in, doing a study with a community agency or several, telling people about disparities and horrible things, and then writing a report or an article, and poof, they're gone. And there's no reciprocity, accountability, relationship that pulls us into a struggle that is beyond us, or beyond a paper, or beyond a project, or beyond a grant, or any kind of timeline that's scaffolded or limited by, you know, the academic structures around us. So I know that people know me before I was academic director of community engaged research and relationships with the Office of Community Engagement, or held this professorship in equity, or these kinds of things. And they've also learned how to be strategic about it, how to wield me for in the ways where, you know, it would be great if we had Dr. Joseph come and speak at the delegation alongside us to share these particular points, to kind of like build the street cred into the academic accountability. And those synergistic kind of strategic relationships are really cool when you learn how to move with community and get things done in kind of novel, interesting ways. So it's like an ongoing learning. How do we deal with the mistrust that people have for academic institutions and researchers that pop in and bounce, and then build trust through that via real relationships, such that we're doing damage control and trust building kind of simultaneously through realness, through action, through showing up. I hope that's a bit of an answer here.
No, that's really, really helpful. And one follow-up question that's unrelated to that, but it seems like the media was really important in kind of helping move the dial, but it also had some consequences, because there was as you mentioned, a kind of hate response. What I've been thinking more and more about is how community engaged research needs to transition more into direct activism, which it sounds like the work you've been doing is in that space. I just wonder if you have any more comments about the role of the media and kind of getting the responses you needed from some of the institutional players.
Yeah, I tend to do a lot of work with activist type organizations because of the nature of the work they do in the populations they serve. It tends to be the kind of thing that, because people are frustrated with systems and services and design, there's like an urgency to speak out and gather and collectivize and mobilize. I've learned a lot from it, and I see that kind of showing up as important in the work. It's not the kind of thing that I would ever write about as like, here's method to engagement and community engaged research. But, it's the kind of thing that sometimes the work demands. And then if you are claiming to be someone who's a part of this, then you have to show up for those things too. And there's risks that come with it. There's accountabilities that are different. And then where we show up in terms of like the background work in the relationship for care and solidarity when you're reaching out to others who are receiving hateful messages, and how we account for atrocity in progress is important. It's risky work. I think, I used to, before I was tenured, I used to chair a committee called the President's Advisory Committee on Building an Inclusive Community. It was a group of 70 folks from across McMaster who were interested in matters of inequity. And a lot of it turned into activism because it had to. And, in that moment, I knew I didn't have tenure and I could be at risk of losing my job, or and I let go of a lot there. And maybe that has helped me be a little bit more agile with how I slip into activism and back and forth. But I'm kind of known for it now, so people kind of know that about me. So it's not surprising anyone. But it's a delicate balance to worry and care simultaneously.
Thank you so much, Amanda. I know you have some questions now in the chat, so thank you.
Thank you. I feel like we could have a whole nother 2 hours just speaking about, how we can do activism well. And that's certainly been a question at CBRCanada as well that we've wrestled with, is what is the role of a researcher, and when are you a researcher and when are you an activist, and can you separate those two roles? So great questions. I'll go to some of the questions that have come up in the chat now. So the first one here is from Marcia. And Marcia asks, for this initiative, were community members / patients involved in the development to determine best approaches?
Yes, in that the community health agencies, the community health centers that I mentioned, the Hamilton Urban Core Community Health Center, Refuge, they were already trying to engage their service users in to understand outreach needs and possibilities. So there were words like vaccine hesitancy and vaccine confidence that I felt were over essentialized ways of talking about the kinds of ways we take up people not wanting to go to a clinic or engage in a vaccination process. And through their work with the communities they serve, we got to have some more nuanced conversations around the fact that it's not just the case that we don't, like, certain communities don't want vaccination. They have a mistrust of health systems that have underserved them. And when you pop in and just say, okay, now we care about you, there's going to be a gap in a relational gap, one that has to be kind of overcome. And that is one example of something that turned into very specific outreach work that, went into high-rise buildings and congregate settings with people from the Somali community, and talking to elders and doing relational work to find out what their needs were, to establish, specialized clinics on a weekend for just said community. So it was kind of not, it wasn't structured as like, we're doing a focus group with the population here in this neighborhood to determine needs and move forward. It was much more agile, but also integrated into the regular work of some of these agencies, organizations, and leaders who have always been doing work with these communities that we were talking about, which was some of the impetus for having advocated for them leading the work, because they do it well. They know what they're doing. So I guess it was kind of ongoing. And feedback. Okay, another part of the story. So when Hamilton Public Health agreed to, allow us to start this clinic, they had their central booking system allow for people to book the priority appointments, and it was really not good. So people were saying things online like, are you racialized? We have a different clinic for you. It was just like, it looked like segregation. It was so messed up. So we heard that feedback and got rid of that system and just demanded that we have the resources to build our own booking system. And then Refuge managed it and just did it through outreach directly through community health centers and the community agencies and our own outreach. So in that way, it was kind of listening and responsive to people trying to access the clinic as well.
What I really appreciate about, all of this, Ameil, and you and I had some very quick discussion about this when we first were planning this webinar, where you had said you don't want it to be really called community-based research. And it sounds like you've done, it's a much more informal sense of that word. You used community-based research or community-engaged principles and ways of leading to the action without it being formal research. And we talk about many different continuums in community-based research, and that's kind of one of them. How formal or informal is it? But you upheld the spirit of what we do in community-based research throughout every aspect of this project, from the way you engaged folks throughout as well. So I really value that, the way that you talk about that.
Yeah, like there are projects that, people, these same agencies, organizations, leaders, relationships have, then since produced and do. And they're more structured, some of those, hey, we want to do this thing with like folks in immigration detention, or people in prisons, or those trying to access assistive devices, these kinds of things. And then we kind of roll out a project. This was just a different kind of story. It just was.
Yeah.
That's
great. And I see, so not a question, but Dave in the chat has posted a link to a podcast where you can hear an interview with Ameil that he says is similarly interesting to what he spoke about today. So a resource there for folks who want to learn more. And then there's a couple more questions that have come in. So one of the questions that came in was just on your last slide there, you had something about ethics and relations of knowledge. And someone has asked if you could elaborate on that point a little bit.
right. So earlier when I was talking about some of the advocacy work, that was kind of pushing back on the idea that collecting socio-demographic or race-based data is action in and of itself. That some of that pushback, I believe, is an ethical argument, in that, First Nations, Métis, and Inuit groups have talked about OCAD OCAP principles: ownership, collection, access, and possession. The idea of data sovereignty being those, the ones who own the data, like who say what it's for and who it's for and what it does, such that it can't be used or wielded against us, you know, to say that we are the burden, the risk, the lack. I believe these are ethical arguments, and they shape our relation to knowledge produced via collection and how knowledge is disseminated and shared, and the ways these matters of solidarity and collectivity and resistance that I was talking about then take up what the knowledge created does for the world. Like, you know, me telling this story is an example of a different kind of thing. The impacts that the clinic had is another one. But if you had just, you know, collected data about who accessed the clinic and, I don't know, the number of phone calls made, it doesn't do this.
It doesn't tell the stories.
Right. And that's an ethical transgression, in my opinion, because if you participate in the kind of consequence that produces the discourses of threat, risk, burden, lack, deficit, by just talking about disparities, then you get into an argument where you're talking about equity as access, or maybe an outcome difference, and not the process and the relationships and the hows and the whys.
Yeah, so we're starting to touch on, I think, another big theme that CBRCanada has been grappling with, which is, you know, in community-based research, there's more to think about than traditional research ethics. There's almost ethics of accountability and relationships with communities that you work with. So I think we're getting into a little bit of that here, the idea of ethics going above and beyond just what we think of as research ethics. It's really ethics of how we use knowledge and our privilege as knowledge holders and our relationships with folks that we've built to gain that knowledge. And you talked a little bit about kind of the idea of data there, and one of the other questions is related to that. Someone has asked what happens with data ownership, since this appears to be a community initiative as a way of advocacy for injustices in society.
Yeah, right. So the agencies, organizations, community leaders, they made intentional decisions around what was going to be collected and what they were going to do with it. And meaning, you know, they decided what they were going to ask people about who were using the clinic, what they were going to collect information on, you know, when people were filling out, you know, surveys to book, when they designed their own system, and what was happening inside the clinic to kind of assess how things were going. And I think that changed the relationship to those we served, because it was agile, because it was responsive, because there were accountabilities to people when you're in neighborhoods where you live and work and operate and serve. You know, it's more meaningful and important to listen and react and help people. And you know, we talked about all of this, and you know, most of what I shared in my slides, which is also kind of in this manuscript in progress, is public because we were noisy. So like you can cite newspaper articles and these public letters and so forth to tell a lot of that story, and the flyers are out there, and you know, we can share those data pieces because they're pieces of the knowledge in the tellings of the stories to complement the renderings of the data that was collected about those served, that demonstrated, you know, just in a small window, they served 6,000 people, and intergenerationally from the hardest reached communities. So, you know, when the province was prioritizing hotspots, the FSAs that were high risk, 2 or 3 of those were identified in Hamilton. We decided to use our own data and identify our own, and we added 2 more to that, and then, you know, started to do a different kind of outreach, not determined by somebody else's data collection, but by people on the ground doing the work who knew what the needs were. and it changed what action looked like. I don't think I could talk about this for a long time. I feel like
So very,
yeah,
very kind of bottom-up grassroots approach, both to
yeah,
data collection and to data ownership as well. The
Mhm.
data being collected by and staying within the communities, and
Yeah.
then being used by those communities in the ways that they thought would benefit the activism. Mhm. That's great. And we have time for one last question. So I'll ask this question from Rebecca. Some researchers or student projects might be limited in time due to the nature of their program or their coursework. So how might you encourage students to tackle health equity respectfully in their coursework and research when they may only have these short-term engagement opportunities?
Yeah, I think being transparent about what you're there for, what you're showing up for, is really, really important. And where you're asked to be. So it's very often the case, even in the Office of Community Engagement at McMaster, where people come to us for help connecting with a researcher that understands a community problem or a research project in a way that they can literally pop in and use their skills, expertise, knowledge to assist in some arm or some stretch of the work that's meaningful, important to the broader struggle, and everyone acknowledges it, knows it, agrees to it, and that becomes like a consensus decision. I think that's very different than, is coming into a place and saying, I'm only here for 6 months. I want to do community engaged research. I have this project in mind. Let's go. And so I think it's, when you get when you're honest about your needs, your approach, the structure to kind of where you come into the work, and understanding that there might be things that happen in the relationship that continue outside of the confines of the timeline that was put in front of you. Yeah, maybe you had a timeline around a specific project, or you were a student, or it was for a course, and you do that thing, but then you're now bound to these communities or this agency or this relationship, maybe forever, in ways that you can't cut, don't want to, and that's okay. That happens all the time. And I think people appreciate that too.
Kind of that ethics of accountability again, as a researcher, once you engage in a community, you're accountable. And that, I think was another theme from the webinar last month, if anyone caught that one, where we talked about building relationships. And one of the key points that came out of that was sometimes those relationships are lifelong, even if the projects are limited in time. And that's how we can build authenticity and trust. Cool. We're going to wrap up the formal portion of the webinar now. So I'll share my screen again as we wrap this up and move into the live discussion portion. All right. So for folks who may have came late or are interested in seeing past webinars, or even just rewatching the webinar today, you can find our webinars on our website at CBRCanada.ca underneath the resource tab, webinars and live discussions. So that's where you'll find the webinar recordings for this and past webinars, as well as webinar slides and any of the summaries from live infographics that we create. Or the infographic summaries of the live discussions that we create. We do hope that you'll all stay in touch with us. So Sarah will post a link in the chat now to where you can sign up for our newsletter. If you're not already signed up, our newsletter will be where you can receive highlights about our upcoming events, as well as events by our partners and members of CBRCanada, as well as other news from across Canada. And lastly, very exciting, CTU Expo is a conference that happens every other year, hosted by CBRCanada. This year, it'll be occurring in Thunder Bay at Lakehead University from June 5th to 8th. We hope many of you will join us. Despite this slide saying the submission deadline for call proposals was January 23rd, we did extend this until February 6th. So Sarah's going to post the link to the call to proposals in a chat for you there in case anyone's interested in a last minute submission of an abstract. You can also find the information about this and when we announce registration and all of that information in our newsletters. So again, sign up for our newsletters if you're not already. We also invite your feedback on the CBRCanada webinar, on the format, and as well as your feedback on what topics you might want to see us tackle in these in the future. So Sarah is going to put the link in the chat for this as well, or you can use your phone or your device to scan that QR code on the screen. Thank you everyone for joining us today. Thank you to Ameil for presenting, to Steve, who is here to represent CBRCanada's board, to Sarah, our volunteer, to all of our participants, everyone who joined us today. We're now going to stop the recording, end the formal portion of this webinar, and move into our very exciting live discussion that we hope you all stick around for.